Good evening, everyone. Thank you for having me. Queer pupil. Our case is a 32-year-old female with headache and blurring more at near that's been for more than a year. So she'd been told she needs glasses, drops, brain imaging. She was told she has increased intracranial tension, glaucoma. She was prescribed ocucarpine, which worsened her headache. And finally, she was told to do a pupilloplasty. So on examination, we found her vision in the right eye to be 0.6 and in the left eye to be 1. And her pupils were mid-dilated, unresponsive to light, and sluggishly responsive to near. She was not on mydriatics. There was no history or signs of a previous trauma, and there were no ocular motility defects. Her foci were normal in both eyes, and there was a history of viral illness that preceded these symptoms. So what can this case be? Can it be a cause of dilated pupils, such as pharmacological or traumatic? In such cases, the pupil would be dilated, unresponsive to light or to near, and would, or even to 1% pilocarpine. But in our case, the pupil was responsive sluggishly to near stimulation. How about third nerve palsy? We would find associated ptosis or ocular motility defects, which were not present. Benign idiopathic episodic mydriasis, in which the pupil dilates in episodes of less than 24 hours, and during the episode, it does not respond to light or to near, and does not respond to diluted pilocarpine, but does respond to the regular 1% concentration. So our case responds to near, and she reports attacks of blurring that last longer than 24 hours. What about the causes of light-near dissociation? There is afferent light-near dissociation, in which a cause in the retina or optic nerve can lead to loss of the light reflex but preservation of the near reflex. But in this patient, both foci were normal. Parinode syndrome, in which there is light-near dissociation associated with skew deviation and convergence retraction nystagmus, as in this case. These signs were also not present in our case. Argyll-Robertson pupils, which are bilateral myotic pupils due to a lesion of Edinger-Westphal nucleus associated with light-near dissociation. Again, our pupils were dilated, not myotic. How about AD-stonic pupils, in which a lesion of the ciliary ganglion causes a dilated pupil that has a tonic response to near and no response to light, and it responds to a diluted pilocarpine test. So we conducted that test, the 0.125% pilocarpine, and we got a brisk pupillary contraction, which confirms the diagnosis of AD-stonic pupil. She was given the diluted pilocarpine to use as needed and requested to follow up in 2 weeks. And she was referred to neurology, who found lost deep tendon reflexes of the upper and lower limbs, which corrects her diagnosis to Holmes AD syndrome. At 2 weeks, she reported an improvement of symptoms. She had only used the pilocarpine twice, and her pupils were 4.5 millimeters at rest, sluggishly reactive to light, which was an improvement to how she was when we saw her 2 weeks before. At near, her pupils were 4 millimeters, and on diluted pilocarpine, you could see the contraction of the pupils, and you could also see a sign specific to AD-stonic pupil, which is sector palsy, in which a section of the iris is less responsive to light than the rest. So what is AD's pupil? They are dilated tonic pupil or pupils with light-near dissociation due to a lesion in the ciliary ganglion, which is the parasympathetic ganglion in the orbit. What are the causes? Most commonly idiopathic, less commonly orbital mass lesions, autoimmune disorders, ischemic diseases, neurological diseases, or iatrogenic causes, such as photocoagulation of the suprachoroidal ciliary nerves during PRP, or orbital surgery or retrobulbar anesthesia. It has an incidence of 4.7 in 100,000, a prevalence of 2 in 1,000, usually affects young adult females. It is usually sporadic and unilateral. If it's unilateral, it presents by anisocoria associated with glare, photophobia, blurring, headache, and hypermetropia or presbyopia. On examination, we usually find a dilated pupil, as you can see here in left AD syndrome, that does not respond to light compared to the other eye showing a consensual light reflex. It does respond to near, but sluggishly. So you could see it has contracted, but not as much as the other eye. and on removal of the near stimulus, it relaxes less briskly compared to the normal eye. Sector palsy, as we mentioned earlier, is a sign characteristic of AD stonic pupil, as well as vermiform contraction, where the sphincter muscle contracts and relaxes repeatedly on stimulation by light. They are responsive briskly to diluted pilocarpine, which usually does not constrict a normal pupil due to upregulation of the receptors, in which case it should be differentiated from third nerve palsy by the associated signs, as we said earlier. It can be associated with hyporeflexia, in which case it's called Holmes-Edie syndrome, or with anhidrosis, called Ross syndrome, with cough, if there's vagal affection, and with a history suggestive of a cause. How to manage? We follow up, we prescribe reading glasses, we give them diluted pilocarpine, and we investigate or refer according to the associations. They are usually not progressive, not life-threatening. The accommodation improves with time, and the dilated pupil constricts with time and assumes a smaller size, in which case it's called little old Addie. The tendon hyperreflexia usually persists, and we have to watch out for glaucoma, angle closure glaucoma in adults, and amblyopia in children. So our take-home message is that AD stonic pupil is not uncommon. It is most commonly idiopathic. The pupil affected is large. It is most commonly unilateral, but can be bilateral. It presents with light near dissociation, and we have to check the reflexes and autonomic functions and follow up for glaucoma and amblyopia. Thank you.
Thank you, Lydia.